But yeah, that's about it.
Yeah, but I guess it also goes with the topic, some topics are very engaging and then I'd say relevant to most colleagues. So I would imagine those tend to be very busy from the interaction point of view.
Yes, they are. Yes,
Yeah.
they are. Kamo, are we ready? I see we're streaming.
Not yet. Not yet, Doc. I'll give you the cue.
Everybody's coming in.
All right.
Okay, good evening, everybody, and welcome to another installment of our Clinics Health Group Thursday webinar. I'm Dr. Motlhabane, the Chief Medical Officer, your host for this evening. And I'd like to introduce to everybody our speaker for this week is Dr. Madumo. Dr. Madumo is a neurosurgeon practicing at Dr. S.K. Mateka Memorial Hospital, managing elective and emergency neurosurgical conditions. He obtained his Bachelor of Medicine and Bachelor of Surgery, as well as Master of Medicine, MMed in Neurosurgery at the University of Witwatersrand. Dr. Madumo has worked as a medical officer, registrar, and then a specialist consultant responsible for neurosurgery patient care, including emergencies, critical care, and surgical care, as well as neurosurgery training towards FC neurosurgery and MMed degrees at Chris Hani Baragwanath Hospital neurosurgery department. He later established a satellite neurosurgery unit with the support of the Wit Circuit Neurosurgery at Tel Moreneng Regional Hospital. I hope I didn't butcher it, everybody. Before leaving state employment, along with working at Dr. S.K. Memorial Hospital. He has a neurosurgery practice at Netcare Waterfall City, where he is in charge of neurosurgery patient care. And he is also a full member of the Society of Neurosurgeons of South Africa, as well as the South African Spine Society. So this evening, I'd like to give a warm welcome to Dr. Madumo, who will be giving us a talk today on subarachnoid hemorrhages. Now over to you, Doc.
Hello, everyone. Good evening, ladies and gentlemen and colleagues. My name is Motlhabane, as Dr. Moresi had said. And today I hope to, to give a talk on subarachnoid hemorrhage. And it is my wish that at the end of this talk that the colleagues would be equipped with the necessary skills to recognize and then as well as to understand this condition and treat it accordingly or facilitate the care of patients with this subarachnoid hemorrhage. So without wasting a lot of time, I would start. So the next slide is an overview of the talk. So I hope to deliver this talk under the subheadings as they appear on your screen now. So we'll first define it and then, go through the causes of the subarachnoid hemorrhage and then how common it is and how does it present so that the colleagues can recognize it. And then the diagnostic test or the investigations required and the management of these patients. and then as well as to go through the well-recognized devastating complications and how to manage them as we go along. So subarachnoid hemorrhage refers to the extravasation of blood in the subarachnoid space, and I mean in the subarachnoid space, which is the space between the pia and the arachnoid membranes in the central nervous system. And it accounts for half of non-traumatic intracranial hemorrhages. You know, the other half, of course, is accounted for by the intracerebral hemorrhages. And the most common cause of subarachnoid hemorrhage is trauma to the head, but there's also subarachnoid hemorrhage that occurs spontaneously, as I've said. It accounts for half of of all the spontaneous intracranial hemorrhages, and there are various causes for that. But for today's talk, we will be focusing on subarachnoid hemorrhage from ruptured intracranial aneurysm. So if you see on the bottom right corner of your screen there is a scan, and on that scan it demonstrates there is some subarachnoid blood. I'll try to use my cursor to point to it. There is some subarachnoid blood in the basal cisterns, and on this scan as well, one can also appreciate the dilated ventricles, or what we refer to as hydrocephalus, which is the common complication of this condition. So the causes of subarachnoid hemorrhage, as I've said, for today's talk, we are focusing on the spontaneous subarachnoid hemorrhage. And as I've said, the causes range from, the majority is trauma, but from today's talk, it's about the subarachnoid hemorrhage from ruptured intracranial aneurysm. So I'll go through the causes of spontaneous intracranial subarachnoid hemorrhage. And as I've said, ruptured intracranial aneurysm accounts for majority of them. And most of those aneurysms are what we call circular or berry aneurysms. But there are other types of aneurysms like fusiform aneurysms as well. And then other causes of subarachnoid hemorrhage other than the aneurysmal ones include lesions like vascular malformations, different types of vascular malformations, including AVMs, dural fistula, dural arteriovenous fistulas, and cavernous hemangioma. But there's also a condition called perimesencephalic subarachnoid hemorrhage, which interestingly arises from it's a venous bleed, as opposed to most of the conditions with causes of subarachnoid that are arterial. So, as I've said, overall, 20% of strokes are hemorrhagic, and half of those are from ruptured aneurysm, is subarachnoid from ruptured aneurysm, and the other half is from intracerebral hematomas or hemorrhages. So 85% of these spontaneous intracranial hemorrhages or strokes, they are from aneurysmal rupture. And then it is thought that patients at risk are those with hypertension, who smokes, and those with a family history as well. And then factors that contribute to this aneurysm rupture are almost similar to you know, factors that, how do I say, that are implicated in the formation of aneurysm, or that put the patients at risk of aneurysm formation. So I do not have the local stats for subarachnoid hemorrhage, but in the US, it's estimated that between it affects 10 to 14 out of 100 individuals per year. And then, as I've said, it occurs mostly between the ages of 40 and 60, in the commonest being between 50 and 55. And then it, in the American statistics, it tends to affect mostly the Blacks and Hispanics than Caucasians. And then Also, the other interesting observation is that females have a slightly higher incidence than males. And then there are speculations that the hormones may have something to do with a slight increase in risk for females. Now, as I've said, I'm hoping to deliver this to assist the colleagues to recognize this condition, but it can present in various ways. I shall go through different clinical scenarios, but the most common or the typical presentation is what we call a thunderclap headache, which a patient most often they'll describe it as the worst headache of their lives. And then it might be associated with nausea and vomiting, some photophobia, or sometimes even features that may resemble a meningitis, neck stiffness and as I've said, and photophobia. In some instances, some patients may have had what we call a sentinel headache or warning symptoms that tend to occur about 10 to 20 days or about we say a week to 3 weeks prior to the actual aneurysmal rupture that present in the classical way of a thunderclap headache. And then other manifestations or other presentations would include things like cranial nerve pulses, especially certain aneurysms in the intercranial arteries, especially the postcom may compress the third nerve and then cause ptosis. And then in some instances, giant aneurysm with thrombi might present with thromboembolic symptoms and leading to focal neurological deficits. Some patients, their first presentation could be, the collapse with a generalized tonic-clonic seizures and or status epilepticus, or in some instances, some patients would present with a sudden deterioration of the level of consciousness. So when we pick these patients, or when patients present with some of those symptoms, we just need to keep a high index of suspicion and then work this patient up accordingly. And then obviously we make the diagnosis, and then the appropriate care can be instituted once we have the correct diagnosis. But once the diagnosis is made, we rely on a number of clinical grading scales that helps us prognosticate and classify these patients. And it also serves as a means for us to standardize the care of these patients. And as I've said, to prognosticate and counsel accordingly. And also during our observation or our monitoring, we are able to pick up the changes in conditions in some of these subarachnoid patients. So the important grading scales, I shall put them in the next slide. We use what we call the Hunt and Hess grading scale, and the WFNS grading scale, or the World Federation of Neurological Surgeons grading scales. We use them to assess these patients so that we can standardize their classifications and monitor their progression of condition as well as prognosticate. So we've went through some of these symptoms, as I've said, other than the classical presentation, some of the symptoms that patients with aneurysms or subarachnoid might present. Coming back to the grading scales on your screen, on the screen you could see I've put both the Hunt and Hess and the WFNS grading scales. To go through the scales just to create what you call just to familiarize everyone with the scales. The Hunt and Hess scale is graded from grade 1 to grade 5. Grade 1 being a mild illness, and then grade 5 being the severe illness, which usually is also associated with what you call poor outcome. On the right of this grading scale, you'd see that there's a survival rate. For grade 1 hand and hands patient, they have a better survival rate in the ranges of 70s. And then grade 2s have survival rate in the 60s, and then grade 3. So as you go up the grades, or as the condition is worse, the survival rate drops, you know. So grade 1 in the hand and hands refers to a patient who present with a mild headache, but other than that, fully oriented with no neurological symptoms. They may or may not have a meningeal irritation findings. And then grade 2 are the patients who might have severe headache, and then still orientated though, and then they might have an associated cranial nerve deficit. For example, if it's a post-com aneurysm that is ruptured, they might have a third nerve palsy. Or if they have what you call raised pressure, they might have a sixth nerve palsy. So those are grade 2 hand and hands patients, and they have a survival rate of about 60%. And grade 3 are usually those now poorly responsive patients, or very confused patients, or very confused. And they may have cranial nerve palsies, and then mild, what you call, motor deficit. And then grade 4 refers to those that are, I would say, they are stuporous, and then they might have a moderate to severe motor deficit. So significant hemiparesis or hemiplegia, or even posturing as well. And then their survival rate drops to 20%. And then grade 5 hand and hands maybe are those patients in a coma that may be decerebrating or that are flaccid, and their chances of survival are low as 10%. So one could use the hand and hands grading scale, but also one has an option to use the WFNS grading scale. I personally prefer using the WFNS grading scale because it's easy for it's easily reproducible, and also it's based on the Glasgow Coma scale that almost everyone is familiar with, you know. So on the WFNS, it's graded again grade 1 to grade 5. But grade 1 are those patients who are fully awake and then with symptoms, and they have no motor deficit. And then grade 2 and grade 3 are patients with a Glasgow Coma score of between 14 and 30. And then the difference is that in grade 2, those patients have no motor deficit, and then in grade 3, these are the patients who may have a motor deficit. And then grade 4 patients are those with a Glasgow Coma score ranging from 7 to 12, and with or without motor deficits. And then grade 5 are the patients with a Glasgow Coma score of 6 to 3. And then again, these ones with or without neurological deficit. So as I've mentioned, we make use of these scales because then when we can see or pick up when the patient deteriorates as a part of monitoring them. And then also it helps us to pick up if there are any new developments in the patient and then treat them accordingly. Now, from the investigations point of view, so obviously once we attend to these patients and then we have we suspect the patient might be having a subarachnoid hemorrhage, possibly from a ruptured aneurysm. The best test to diagnose it is a non-contrasted CT brain, which is able to pick up blood in the subarachnoid space, as you've seen in the slide I've shown earlier on, but I have other subsequent images that I shall show. Because on non-contrast CT scan is able to pick up the blood in the subarachnoid space. And then Obviously, with the CSF flow and over time, as well as the red blood cell lysis, as time progresses, the sensitivity of a non-contrast CT scan does reduce. So it becomes less sensitive as the blood breaks down and it circulates in the subarachnoid space. But in most instances, it is very sensitive and specific. So it is the most reliable test for us to pick up the subarachnoid hemorrhage. Now, on those patients, for example, who present or on the scan, there's no obvious subarachnoid and there's a high index of suspicion. Those patients, a lumbar puncture can be performed. And then the feature to look out for on the lumbar puncture, it's a xanthochromia. So the typical discoloration of CSF from red cell breakdown will distinguish the subarachnoid hemorrhage from a bloody tap, because usually the bloody tap would not, there would not have been enough time for red blood cell lysis to happen. And obviously, for LP to be sensitive, one needs to do it at a time after the red cell, or when there has been enough red cell lysis, which typically is about 6 to 8 weeks, to 8 hours after the initial CT scan. And then the other feature, one could look at when they are doing a lumbar puncture at the bedside, is that if it's a bloody tap, the CSF tends to clear, whereas if it's the blood that is picked up on the cerebrospinal fluid is from the subarachnoid, the blood does not clear on the CSF. It's actually persistent, before obviously one is subjected to centrifuge as well as or observing xanthochromia. And then obviously once the diagnosis of subarachnoid is made, the cause needs to be identified, So CT angiogram should be performed without a delay. Because from the CT angiogram, we'll be able to identify the vascular lesion, in this case, typically an aneurysm, as you've noted, that is the most common cause of non-traumatic subarachnoid hemorrhage. And then that aneurysm, one would be able to locate it from the CT angiography and then look at its other features, because that forms part of planning in terms of definitive treatment of the aneurysm that would have been diagnosed, or the vascular lesion that would have been diagnosed. And then in most instances, following a CT angiogram, or in instances where the CT angiogram is negative and there's a high index of suspicion, the DSA would be performed, or the formal angiogram would be performed. So the advantage of a DSA is that you are able to study the vessels individually. So in addition to giving you the features that you could pick up from the CT angiography, you get more details, as well as the what you are able to perform individual runs. And then it also allows for intervention, for example, coiling of the aneurysm, or it assists with surgical planning if the said aneurysm is not amenable to coiling or endovascular treatment. But the other advantage is that in the event there's a vasospasm, it can be treated during angiography. And then also certain tests like occlusion tests could be performed to see, especially in instances where it might aid in terms of the definitive treatment. The only disadvantage is that it is pretty invasive, and then it has its own risks. And then MR angiography, it's another investigation that can be performed to confirm the aneurysm, as well as to look at the features of the aneurysm and assist with the treatment planning. And MR angiography, the advantage is that for patients with renal impairment, or in instances where iodine contrast agents cannot be used immediately, One can subject the patient to what we call time of flight MRA or MRI angiography, or TOF MRA for short. And then it should be able to diagnose or to assist with the diagnosis or confirmation of an aneurysm without the use of contrast. And also the other advantage when one is performing MRI angiography, the MRI angiography is able to detect the products of blood breakdown, especially in those instances where maybe there was a high index of suspicion and then the CT scan couldn't pick up the blood or confirm the subarachnoid, but the MRI is able to pick up that even once the red blood cells have lysed. Now, radiographically, there is what you call a Fisher grading scale, and then there's also what you call a modified Fisher grading scale. Now, the purpose of this scale, it is based on the CT scan, and it provides insight into the amount of the subarachnoid that one picks up on the CT scan. And it correlates with the severity of the bleed itself and the location of the bleed, the ruptured aneurysm grade, as we've seen in the clinical grading scales. And then by doing so, it helps us predict the vasospasm incidence. So the modified Fisher grading scale is depicted on the right of your screen there. And then it's graded from grade 0 to grade 4. Grade 0 being in instances where one is not able to pick the subarachnoid hemorrhage itself, and then no intraventricular hemorrhage, and then the probability of complication or ischemia from the vasospasm, it's 0 in patients who have a grade 0 modified Fisher subarachnoid. And then in patients who falls into grade 1, meaning patients with a small amount of subarachnoid, but that can be picked up on the CT scan without intraventricular extension or hemorrhage, the probability of cerebral infection, infarction or ischemia increases to 6 to 24%, as opposed to in grade 0 where the blood is not detected on the CT scan. And then for grade 2 is that the patients still who have the same amount of blood in the subarachnoid system or thin subarachnoid, but then in addition, they also have some intraventricular hemorrhage or extension. And then you'd see that this patient have a higher probability of cerebral infarction. And then grade 3 being patients with a lot of subarachnoid, or what is called thick subarachnoid, and then but no extension into the ventricular system. If you see, their risk is almost the same as the grade 2. And then grade 4 are patients with a thick subarachnoid hemorrhage, but thick subarachnoid hemorrhage, but with intraventricular extension, and one can see that they are at a higher risk compared to the other grades of a probability of cerebral infarction. So a couple of issues with this modified Fisher grading scale that is based on CT. One of the issues is that these probabilities is different for different studies, but as you can see, it average quite wide. And then the other issue is that the Fisher study, it did not specify the criteria of what would be defined as thick or thin subarachnoid hemorrhage. But the general consensus is that when the subarachnoid hemorrhage completely fills the fissures, and the cystence is considered to be thick. So those are the limitations or the issues with the modified Fisher grading scale. However, radiologists use it, or we do use it, because it helps with the prediction of the probability of cerebral infarction. So I've put a few CT scans demonstrating the subarachnoid blood. So on the first scan, one can see there's thick subarachnoid blood or lots of subarachnoid blood. Essentially, the fissures and the cistern are completely are full of blood, completely filled with blood. And then in this scan as well, there's also an associated ventricular dilatation and fissures of raised intracranial pressure. So this is a patient with a subarachnoid that already have the features of hydrocephalus, so thick subarachnoid with features of hydrocephalus already on that scan. And then the scan on your right, it shows the patient who had interhemispheric bleed in this one, so a bit of subarachnoid, but a clot in the in the interhemispheric fissure and the anterior interhemispheric fissure. And this patient, upon further workup, had typical symptoms, and upon further workup, it was confirmed that the patient had an aneurysm as well. But on this patient, as you can see, as opposed to the other patient with thick subarachnoid hemorrhage, this patient didn't have ventriculomegaly or hydrocephalus. So this is how the subarachnoid would look on the non-contrasted CT brain. And then the CT angiogram, which is a test now that will confirm the location of the aneurysm or the cause of the subarachnoid hemorrhage. In this one, you could see on the picture on your left, it's a sagittal view or side view. It's a CT angiogram, and therefore you can see all vessels are depicted because one cannot selectively run the anterior circulation on one side and then the subsequent side, and then as well as the posterior circulation on either side. So in this one, all vessels appear there after the contrast administration. But what one can pick up is that in the region of the anterior communicating artery, right there seems to be an aneurysm, and then you can confirm it on another view, top to bottom view, that aneurysm in the anterior communicating region. And then in addition to that, the other finding is that the vessel on the A1 or the first segment of the anterior cerebral artery on the right-hand side, it looks narrowed. Either it's hypoplastic or there might be some vasospasm as opposed to the other one on the other side. All right. And then the next picture shows also patient with lots of subarachnoid, the fissures full of blood, and the interhemispheric fissure as well as the cisterns. But in addition, on the right side, there is an angiogram picture depicting a distal anterior cerebral artery aneurysm there, which correlates, by the way, with the area where there's a bleed there on this patient. And then the formal angiogram or the digital subduction angiogram, the images would look like this one we see on the screen, showing the aneurysm name. And then, as I've mentioned on the digital subduction angiogram, this is a different aneurysm. It's not the same as one is seeing there. But I wanted to demonstrate that it can be coiled endovascularly. So through the angiogram, a microcatheter and the coils are deployed in the aneurysm, and then it facilitates clotting and thereby occluding the aneurysm, and then definitively treating it and reducing the risk of rebleed. Now, when these patients present, as I've said, one needs to have a high index of suspicion, and then emergency care physicians need to recognize these conditions. And once diagnosed, or once the patient is confirmed to have subarachnoid hemorrhage from aneurysm or suspected to be from aneurysm, this patient needs to be managed in ICU. And then it requires a team approach. So the intensivist, the physicians, a neurosurgeon, neurologist, and the ICU nursing staff, as well as the allied healthcare professional, needs to work together for the care of this patient. And it is important to counsel the patient or the relatives as well, because this condition has a high mortality rate, and then it's associated with a poor, neurological outcome even for patients who survive. But there are things that for this patient are considered standard. Some of these patients come with elevated blood pressure that might be stubborn, and then the blood pressure would need to be treated aggressively. But then one is to avoid the sudden drops in blood pressure, because that could predispose to ischemia. But obviously, if the blood pressure remains persistently elevated, the risk of re-rupture is high for those patients. So the target blood pressure is a systolic blood pressure of 160 millimeters or below, or ideally between 130 millimeters of mercury to 140 millimeters of mercury. And then there is a standard of care that includes what we call subarachnoid protocol, where we give patients anti-epileptic drugs, calcium channel blocker and therapy, and stool softeners and analgesia. As you go through the medical treatment, I'll explain this in detail. And then for patients whose aneurysms are secured, in the event they experience a vasospasm, one needs to treat it aggressively with what we call triple H. So load the patient with fluid, thereby inducing hypervolemia, and then artificially elevate the blood pressure to try and overcome the effects of vasospasm and prevent the irreversible ischemia. And then as well, those patients with poor grading, usually grade 3 to grade 5, may require ventilatory support. And then it is important when these patients are in ICU that are monitored adequately. So when these patients are in ICU, for those who have elevated blood pressures and need aggressive blood pressure treatment, one needs to consider the use of a arterial line so that they could monitor the blood pressure and treat accordingly. And this patient needs to have hourly neurological observations in ICU. And as I've said, the aim of looking after this patient in ICU is that we could pick up the complications that typically occurs with subarachnoid hemorrhage and treat them accordingly, so that the patient might survive the ruptured aneurysm, and also to reduce or to manage the risk of neurological deficits that comes with what you call subarachnoid hemorrhage from ruptured aneurysm. And one way of picking up a vasospasm is to use the transcranial Dopplers. The disadvantage of transcranial Dopplers is that they are operator dependent. So it would depend on the skill of and the interpretation of whoever is performing the transcranial Dopplers. But if performed well, it may detect a vasospasm prior to clinical manifestation, and thereby allow confirmation by angiogram and intervention to reverse that vasospasm or to treat it. And then EEG is also one of the ways these patients are monitored in ICU. And then it's strongly recommended for those patients who have unexplained neurological deterioration, or where there's a suspicion of subclinical seizures or poorly controlled seizures. EEG monitoring in that case, it's recommended. And then other tests that could be done as part of monitoring this patient would include perfusion scans or CT angiogram. And then is to pick up the vasospasm. And then obviously once the vasospasm is picked up, one could treat it by the use of, angiography and either balloon angioplasty or even intraarterial injection of perpetrin. But part of monitoring these patients is to pick up if they deteriorate, because should they deteriorate, the common causes of deterioration is vasospasm with ischemia or rebleed or what you call hydrocephalus. So when these patients do deteriorate, repeat imaging should be performed without a delay. And because one of the things that could be done for those with a hydrocephalus or elevated ICP, the ventricular drain may be placed, and the advantage of placing the ventricular drain is that then the ICP monitor can be directly monitored, and also the ventricular drain allows for therapeutic drainage of the CSF, you know, and then so in conjunction with diuretics, it might help one manage the ICP in these patients and then treat accordingly if it's elevated. Now, the issue of rebleeding, as we are aware that patients with subarachnoid, spontaneous subarachnoid hemorrhage tend to rebleed. They either rebleed or get vasospasm or get hydrocephalus. So it is important we manage the blood pressure accordingly, because for persistently elevated blood pressure, those patients are at high risk of bleeding. And then also the other risk factor, those patients with poor Hunt and Hess grading, usually grade 3 to grade 5, they are at high risk of rebleeding, and they should be observed closely. And then patients with intraventricular extension or with associated intracerebral hematoma, they are at risk of rebleeding. And then as well as patients with large aneurysm size 10 millimeters and above, and as well as the posterior circulation aneurysm, those patients are associated with a high risk of rebleeding with even higher mortality and morbidity. Now, with regard to blood pressure control, oftentimes these patients with elevated blood pressure that are in ICU, they would be receiving medical treatment for subarachnoid hemorrhage, which often includes calcium channel blockers, which might help with blood pressure control. Or sometimes they may also be on mannitol for what you call elevated ICP. But if the patient still having an elevated BP despite those therapies going on, it is advisable to use other agents to manage the blood pressure, because as we've noted in the previous slide, is that an elevated blood pressure is a high risk for rebleeding, you know. So agents like labetalol and hydralazine are preferred, and they can be used in those doses. And then other options include the other calcium channel blockers. But as I've said, in most instances, patients with subarachnoid, they would have been on a calcium channel blocker in the form of a nifedipine, because it's a part of standard of care. So our agents really that we use for those resistant blood pressures is labetalol and hydralazine. And sodium nitroprusside is better avoided because one of its side effects, it can precipitate intracranial hypertension. So it's best avoided in these patients. And then, as I've said, of the two agents, labetalol and hydralazine, yeah, the physician or the practitioner could pick whichever one they are familiar with. And then the other measures, as I've said, they include the prevention of vasospasm. That's where the calcium channel blockers come in. Nimodipine, it has demonstrated consistent result in reducing delayed cerebral ischemia in this patient that usually occurs as a result of vasospasm, and then is part of standard of care for patient with aneurysmal subarachnoid. And we tend to give it in the doses of 60 milligram every 4 hours, either orally or per NG tube. But for those who can tolerate it well or that it induces hypotension, the dose could be halved and be given every 2 hourly. All right. Then magnesium is not recommended for routine use in aneurysmal subarachnoid because it has not shown any benefit. And then as well as endothelin antagonists, they have not shown any benefit together with the statins. And then for patients who are on anticoagulants, when they present with subarachnoid, it is best to discontinue all anticoagulants and reverse them accordingly, because the issue with anticoagulants is that it will increase the amount of bleeding when the rupture happens or the re-rupture happens. And then we have noted in the previous slides that the more blood in the subarachnoid space or in the ventricular system, the outcome tends to be bad. So it is best to obviously stop the anticoagulation agents and refer them. Obviously, one would have to balance it with the risk of what you call thrombosis, but then things like mechanical devices and early mobilization for some of these patients and ensuring adequate hydration might assist with those what you call those thrombotic incidents or conditions. And then once the aneurysm is secured, one can reintroduce the low molecular weight heparins or unfractionated heparin 24 to 48 hours, but provided the aneurysm has been secured. And then the other factor, these patients tend to have lots of pain, severe headache with neck pain and sometimes with back pain. And then they also tend to be anxious. So pain control while they are in ICU is very important. But also when one is using pain medication, we should be aware of oversedating the patient or giving agents that would potentially oversedate the patient and make neurological examination difficult. So it is recommended one to use paracetamol, and then of the opioids, morphine titration seems to work well. And then the other painkillers also can be used, but it is also better to avoid the non-steroidal anti-inflammatories. And the other part of medical treatment for this patient, routinely we place them on anti-epileptic drugs, either as a prophylaxis or for those who've had a seizure as a treatment. And our options include sodium valproate or epilim, or phenytoin as well. You load the patient and then you follow it up with the maintenance dosages as well. And then for those who are in status or continue to have a seizure, a second agent may be added. Commonly, we would use a Keppra as an alternative, or even in patients who have side effects from sodium valproate or phenytoin. So one can move on and use a Keppra or use it as an add-on. And these patients, we use stool softeners, and then this is to assist them not to strain or to Valsalva, because that might elevate the blood pressure and further increase the risk of rebleeding, especially because they might have constipation because they are on opioids, and then they, we tend to put them on bed rest. So the use of stool softeners, it's highly recommended as a treatment of patients with subarachnoid hemorrhage, and we use it routinely. Now, coming to the treatment of the aneurysm itself, once the patient is stabilized and then it's ready for definitive treatment, and the aim of definitive treatment is to what do I say, to definitively treat the aneurysm and thereby avoid the risk of rebleeding with these complications. So we have two options. We have surgical clipping of the aneurysm, which is done via craniotomy, and it's a microsurgery. depending on where the aneurysm is located. And the other options include endovascular coiling. And then other surgical treatments, as you've seen, for those with hydrocephalus or elevated ICP, CSF diversion in the form of an external ventricular drain, and the monitor is placed, and it serves both as a as a guide for monitoring the ICP, and it also enables one to drain the CSF or to treat the elevated ICP, so to say. Now, the timing of definitive treatment is a subject of controversy for decades. There are people who believe in early aneurysm securing, and then there are instances where it is beneficial to delay the surgery and secure the aneurysm later. But then, as you would imagine, for as long as the aneurysm is not secured, the risk of rebleeding and the other complication remains high there. So in general, early surgery or coiling is recommended, as you can imagine, because it would reduce the risk of bleeding. And it's recommended for patients with aneurysms that are less complicated and have a favorable grade. Right. And patients with a poor grade or who fail to improve after stabilization measures may not be treated, as an emergency. It might be better to treat them with coiling and at the later stage once they have settled. So, now, the picture on your right just shows you what we call a aneurysm clip. So this is placed via craniotomy and microsurgical dissection under the microscope, and you identify the aneurysm. So now, recently, endovascular treatment of aneurysm has been gaining popularity, and in fact has been preferred in most instances than surgical clipping because of the low morbidity associated with it. And however, the choice between the surgical clipping and coiling depends really on the expertise available and where the aneurysm is located, as well as the features or the characteristics of the aneurysm, because there are certain aneurysms that are not amenable to endovascular coiling. However, with the recent advances, most aneurysms can be treated with endovascular means or by endovascular coiling. For example, aneurysms, some of the aneurysms that were considered not amenable to coiling. These days, one can have what we call stent-assisted coiling. One could also have balloon-assisted coiling, and then together with other devices like flow diverters and that. So endovascular treatment, in fact, it has advanced to a point where it's able to treat most of this aneurysm, but equally, the microsurgical in centers where microsurgery is practiced and there's more experience and expertise available. It has also advanced to levels where in good hands, the results are as good as with endovascular coiling. So it really depends on what is available and what is the expertise, because also at the center of all of this is the patient and the better outcome possible. Now, this is what this is a sketch on your left-hand side that shows how the coils are looking. And then on this one, I'm showing the stent-assisted coiling. So you could see, because the aneurysm is a wide neck, there's a stent placed there that helps or that prevents the coils from prolapsing and causing occlusion distally or migrating to cause occlusion distally. And then on this, the other picture here, I think you've seen it earlier on, but it just shows how the angio runs look after the aneurysm is secured. As you can see, the aneurysm is no longer filling with blood because of it's now packed with coils. So really, this slide reiterates some of the points you've made, that aneurysm coiling is an increasingly practiced alternative to surgical clipping. And then also endovascular coiling is favored for posterior circulation aneurysms. And then for those patients who have a higher clinical grade, they are very sick, or they have significant medical morbidities and are not fit for surgical treatment, coiling rather than surgical clipping tends to be a best option. And then also the other advantage of endovascular coiling, as we've mentioned earlier on, during coiling, if there's vasospasm, it can be diagnosed, and then it can also be treated either by balloon angioplasty or by papaverine intraarterial injection. Now, the complications of aneurysmal subarachnoid hemorrhage, I've just put them here in this slide, but it just, as I've said, for a patient who's been monitored in ICU, if they deteriorate, they could be having a bleed, they could be having hydrocephalus, or they could be having a vasospasm with ischemia. So when these patients deteriorate, it is a must, or they should be taken for imaging studies to diagnose what really is the problem. Because if it is hydrocephalus, it can be treated with CSF diversion measures like external ventricular drain. And then if it's rebleeding as well, it can be treated accordingly, depending on the patient's condition and whether or not the patient needs a surgical evacuation. The throat can be evacuated and the aneurysm clipped in those cases as well. And then in some patients, if the patients deteriorate because of vasospasm can be confirmed on a formal angiogram, and it can be treated as you've seen with a balloon angioplasty or intraarterial papaverine injection. And then the other complication is raised ICP with herniation syndromes. And then obviously this calls for management of raised ICP, which will use things like mannitol or diuretics, and then as well as some various decompressive surgery, provided they are in that patient, they are indicated. So they can be, the raised ICP with herniation symptoms can be treated accordingly. All right. And then the vasospasm leading to cerebral ischemia, as I've said, it can be treated. And then these patients, while they are very sick, they can get other complications, not only the ones related to the central nervous system, but they tend to have neurogenic pulmonary edema, which should be treated accordingly. And they may have some cardiac dysfunction in the form of dysrhythmias, and these tend to be benign and they resolve. So most patients with a rupture with aneurysmal subarachnoid tend to have some ECG abnormalities, but then this can be treated. And while in ICU, like all ICU patients, they are at risk of deep vein thrombosis, sepsis, pressure sores, and then electrolyte imbalances, particularly hyponatremia, which should be closely monitored and treated accordingly. And then, ultimately, some of these patients, or a large number of these patients, don't make it from rebleed and or some of these complications. And then those that survive sometimes are left with a significant morbidity. So this is how I intended to cover the topic for today. I thank you all for your attention. And then at this stage, I think we could take questions and comments.
Thank you. Thank you very much, Doc. Thank you for that. I see colleagues are colleagues have also joined us from all over, stating that it's become a very informative talk for us today. So, Doc, just from my side, I have one question. You mentioned that at one point, it becomes too late for a non-contrast CT scan. What is too late exactly? Because I know in another investigation you talked about 6 to 8 hours after, but what is too late for a CT scan?
Yeah, it's not necessarily too late, but then if, for example, there wasn't a lot of blood in the subarachnoid space, right? And then those red blood cells get lysed, one may not pick them up on the CT scan. So however, if there's lots of subarachnoid hemorrhage, like those thick slices you've seen, that subarachnoid pattern can continue for days sometimes, or even for before that blood clears. So it's more about how much subarachnoid was there, in the first place. The less subarachnoid there is, the higher the chances that the CT scan might miss it, because the CSF circulates quite a lot in the CSF. So in the central nervous system. So if there's fewer red blood cells, they might be washed off to a point where you don't pick them up on the CT scan.
Okay, thank you. We've got a question from Mohammed. He says, is there any role for epsilon, Mohammed, ESP, especially, epsilon aminocaphoric acid, especially in rural areas? I hope I pronounced it correctly, Mohammed.
Maybe Mohammed could come on and just yeah.
Kama, I don't know if there's any ways we can get Mohammed unmuted for him to ask his question.
Hi, Doc. Yes, I've allowed everyone to comment, so you can comment this.
No,
Mohammed?
Mohammed, are you allowed to speak? I can't see Mohammed now.
But he was asking about aminocaphoric acid, right?
Yes, that one. Is there a role for it?
It's an yes, it's an antifibrinologic agent. In some instances, especially those patients that what you call, they are at risk of rebleeding, and then they can't access the facilities, and that it can be used, but it is not routinely used. So it is not one of the treatments to be routinely instituted. So I wouldn't say anyone who's in the rural areas, when there's aminocaphoric acid, and then they give the patient. So we don't routinely give it.
Okay. And then I think for me, if you were to just go back on the complications, maybe I may have missed it.
Okay.
When you've listed them, I assume you have listed them in the order, and I'm making assumptions of the most common complications, but that would be rebleed. And other than rebleed?
Yeah, look, in fact, these complications I've listed, they are all common. They are all relatively common. So the rebleed, it's a time dependent. The risk of rebleed is time dependent. So such that most patients would rebleed in the first 24 to 72 hours of admission. But however, until the aneurysm is secured, they are at risk of rebleeding at any time. But the highest risk, it's in what you call, in the first 72 hours is the highest. And obviously within that month, when they've had a subarachnoid, they've had an aneurysmal rupture, they are at risk of rebleed. Now, the second risk, the hydrocephalus, say up to 30% of patients with a subarachnoid with intraventricular extension do get hydrocephalus. So that's a huge percentage as well. And then Vasospasm, it affects, I would say, between 60 and 70% of this patient. However, it is not always symptomatic. So radiographically, if you subject this patient to angiogram studies and that, one is able to pick up vasospasm, even on the angiograms that we use to what you call diagnose the aneurysm. You can see some vessels may be what you call in spasm at the time. It's not symptomatic in all of those cases, but up to half of them might have symptomatic vasospasm with ischemia and a secondary infarction. So they are all common. And then to a variable degree, these patients have raised ICP, almost all of them, but it is significant in some of them to a point where they need intervention, especially the ones who have associated hydrocephalus. So when the subarachnoid bleed, the brain swells in almost all of them. So to variable degrees, they've raised ICP, and then it is significant in others. Now, the ones who will have hydrocephalus and vasospasm and ischemia, the ICP tends to worsen, and then those are the ones who subsequently deteriorate.
All right, thank you. All right, so we've got a question from Kobile, who says, how do you manage SAH in a rural area without all of these expensive imaging you mentioned? And how effective is EVD?
EVD is very effective, as I've mentioned. It's relatively easy to place in a patient who has indications for it. So who has ventriculomegaly or dilated ventricles. It's easy to place, but it will drain the CSF. But the disadvantage of placing an EVD in this situation is that if you think about it, there are forces at play, you know. So you have an aneurysm with a weak wall that has intramural pressures, which, you know, are closely related to the patient's blood pressure, depending on the presence or the absence of a thrombus. And then these vessels are sitting in a space that has its own pressure, the intracranial pressure. Now, if you place an EVD and then you reduce the intracranial pressure, there is a risk of you precipitating a rebleed, you know. So even though at that time you're addressing one problem, but by changing the transmural pressure, when you decrease the intracranial pressure, there is a risk of you causing a rebleeding or worsening the bleed now. But obviously you can treat, you know, what you have to treat. It wouldn't be justifiable for patient to deteriorate and die from hydrocephalus because you're worried about the patient rebleed. The patient may or may not rebleed. So the risks is justifiable, so to say. And then the first question, how do you manage this patient in a rural area? I think the emphasis is on one, being aware of the condition, and then having a high index of suspicion and making, you know, the clinical diagnosis and transferring the patient to a facility that can confirm and treat the condition. Because in the rural, I would imagine, if you don't have the required specialist, or in fact the facilities like an ICU to look after that patient, there's not much you could do, you know. So I think if you recognize the condition and then expedite the transfer of that patient as soon as possible, you would have done mostly what you can. And then for those patients with poor grading that needs to be resuscitated, obviously this knowledge of how to resuscitate them, secure their airway, manage the blood pressure, and once they are stable, moving them to a facility that can look after them.
Okay, thank you. Dr. Abefemi, that's not the topic for today about spontaneous SAH. We'll keep that topic for next time. I just like to thank everybody because it is now 7:09. And what we will do is any unanswered questions, we will send it through to Dr. Madumo, who will answer them and send them through to, and we will then disseminate them to everyone. Dr. Madumo, I want to thank you so very much for this highly informative talk tonight. Many of our colleagues have commented on the fact that this has been new knowledge for them, and it's amazing for them. And also thank you for that last question, the answer as to how to assist our colleagues out in the rural areas in managing these patients, having high index of suspicions, and being able to stabilize them for transfers onto higher levels of care. So I want to thank everybody for joining us tonight. And Doc, we'll call you back for another topic. But thank you so very much to everybody. And once again, thank you and good night.
All right. Thank you, everyone.